Thanks very much, Conor, for that presentation. And we're now going to move to the panel discussion. And as we put everybody up on the screen, just to note, Conor can't join us. Conor has led out my MGTI program, and I think he's given us a really good insight into the quality and the challenges that occur with this program. So unfortunately, I think he's on call, so he can't join us. So we're going to move to a panel discussion, and we've about just about 20 minutes to discuss some of the issues. And we're joined by Professor Mary Horgan, Dr. Laura Durkin, Professor Anthony O'Connor, Professor Frank Murray, Dr. Hassan Muzami, and then Professor Cathy McHugh. And I think we've covered a fairly broad, to say the least, area of challenges in our health service when we try and create a training environment. And I'd like to talk a little bit about generalism and specialism, as we definitely noted from the talks that these are generally, there's a big overlap here. And just to kick it off, Laura, I suppose listening to Anthony's
has Anto frozen?
Looks like he has.
Yeah,
okay,
sorry.
Well, okay.
So Laura, I don't know if you heard that question listening to generalism. Did you answer it when I was off air there?
No, I didn't hear it.
Sorry, and again, I've probably wasted a minute now, but this is technology, I suppose. These are the challenges. When I was thinking about the presentations, there's so much overlap, but is it fair to say the average consultant in Ireland really has a preference to specialty over general medicine? Would you think that's a fair comment? What's your thoughts on that?
So it's tough, because it's always easier to do the thing you know a lot about and the thing that you can be efficient at. So that it's easier to do your specialty, but that doesn't necessarily mean that it's more enjoyable, or that it's like, for me, I get a huge satisfaction out of things that get better. My disease is, if I diagnose one, I have that patient for life. Whereas there's a real satisfaction seeing people with things where they go home from the hospital and I can actually cure them, in like, as opposed to my specialty work, which is, you know, I will have a relationship with that person until I retire. So it's really nice to have that variety, and I hope that most people see value on both sides of that. But just because something is easy, we shouldn't really have a preference for doing the thing that is just quicker and easier for us. It's not necessarily the most important bit of our job.
Yeah, I think, and thanks very much for that answer. I mean, that is illustrated in Anthony's talk as well, you know, in the split on the post-call ward round and the abilities to, you know, the different spectrum of those things. But Anthony, you mentioned COVID. I mean, has COVID shown us the answer here already? What do you think? You mentioned it in your talk. What would you take out of your experience in COVID in the context of our hospital settings in delivering care?
I suppose from a very personal perspective, I enjoyed the actual work of it more than I thought I was going to, you know. I was able to round every day. I was able to keep on top of the ward. All my patients were cohorted into one place. I could go up to the ward at 4:30 every evening and just check in, look to see who's deteriorating, keep a closer eye on things, and rather than, you know, trying to keep so many balls in there at the same time. So I thought that was quite instructive, and I wonder if going forward that's a model that could be looked at, that if you do have a particular component of your job that's general medicine, that you do that and then maybe throttle back on some of your other duties during that period, and then, you know, at other times, I mean, it's just it's one way it could be looked at. I don't think there's any perfect system, but certainly I do think the system was really stress tested during COVID, and I think a lot of things performed well, and I think we need to look at those as to how we're going to build for the future.
Yeah, and I think consensus is rare, but I think those answers are consensus. It's having the time to do it right. And I suppose what I'm going to ask now, I might ask Laura first and Anthony, but anyone else who wants to join in, I mean, is the issue here that we don't champion medicine, that we need avenues to champion medicine. And I'm going to just, one of the questions that came in, it was an interesting way they put it, was does the healthcare system, is it really our training system that there's overweening from medical schools and teaching hospitals, i.e. the idea being that, you know, we're not really championing medicine early in our careers. What would you think about that? Laura, what do you think? Is this an issue that we don't give it enough press early on, that when people come into medical school, it's always about being a gastroenterologist or a rheumatologist rather than a general physician?
So I actually had this experience in my SHO interviews. So I was a happy medical intern and I liked everything that I did. And I was really enthusiastic about everything. And I went to my SHO interviews and they said, what do you want to do? And I said, God, you know, I've absolutely no idea, but I really want to do hospital medicine. And I could see them immediately write me off. And I got feedback after that interview that I was the worst interviewee that they'd had in a long time. And that I was really disappointing in person. And it really made me, like, and I know I'm on the side of the specialist and I'm a very happy specialist, but it really made me reflect on things, because I think that, you know, our enthusiasm for whatever it is we do, it's good to have one thing that you're really, really good at, because that makes you, you know, that makes you enthusiastic and gives energy and propels you onwards, and hopefully will sustain you for all the things that perhaps you don't know that much about and maybe you need to learn a little bit about. So I do kind of agree in some of what that person says, but we do need to champion the kind of, you know, the day job as well as the specialty, because it has to be both.
Yeah, I think that's a good answer. And I think, Anthony, what do you think? How would we champion medicine if we take the day job? I mean, I would tend to agree that, I mean, you know, really focus on it, as you've mentioned in your talk, is probably one of the key issues. But is there anything else you think is important in that regard?
Well, I do think we're sort of blessed in medicine that we do have some people who are genuine sort of polymaths and who are really fascinated by all aspects of general medicine, and that are very interested also in how care is organised. And I think, without naming, I thought Declan Byrne would be one example that would sort of spring to mind of that sort of person. And I think people like that really should be endorsed and should be rewarded. And I think sometimes when we're talking, sort of coming out to dishing out grant funding and things like that, sometimes general medicine can get sort of pushed to the end of the queue a little bit, and maybe to make it more of an academic bent. But I do think there's definitely more we could do within the specialty, first of all, to promote and medicine, general medicine, and help general medicine assert itself. And then I think in the sort of wider healthcare system beyond that, because don't forget, as I keep saying, it is the core business of our hospitals is general internal medicine. There's no getting away from that.
So thanks.
May I just say something for a moment?
Yep, absolutely. Yeah, Kathy. Yep.
If I just say that we have, at the moment, we have general medicine SPRs, and we keep getting asked, would you like specialty SPRs? And I actually really enjoy having the GIM SPRs. I have a geriatrician, or a geriatrician in the making at the moment, and I learned so much about stroke from him. I had a cardiologist last time. I just, so much to learn. It's a two-way street. I really enjoy having the general, somebody that's different, that thinks slightly different than I do. They're not in that endocrinologist conveyor belt that juices everybody with the same thing. I quite enjoy that. I think there's a lot to give.
Yeah, and there's a lot of things that we do very well, and I think it's trying to look at how we can improve that. I want to just ask a couple of questions before we move to the second. The time goes so fast. The one of the elephants in the room is whether we should be training standalone acute physicians, and I don't know if anyone has any views on that. I got the themes from the talks that dual in the right setting. But has anyone got any views on the role of an acute physician in the future, standalone? What do you think, Laura? What do you think?
So obviously the UK use that model. They've trained lots of people in acute medicine specifically, and they start from the beginning of their SPR in that. Now they have a setup where they have very standardized pathways through their emergency departments and AMUs for those acute medicine trainees and consultants. And I suppose that's in the setting of a vastly different consultant workforce and population. So I can see how it sounds it sounds very attractive, but from a personal perspective, as a trainee, I would have thought that sounded great. But as a consultant, I would now think that job has a very limited lifespan. If I was doing nothing else, I think the risk of burnout in those posts is huge. So I'm kind of on the fence a little bit. As a trainee, I would have been very vulnerable to one of those pathways, but as a consultant, I don't know that I would have been had a sustainable career in it.
Okay, great. And I think, again, these are really important questions because our health service may not be able to accommodate that, but there may be ways of integrating, both types of posts in a system without necessarily all acute medicine. Just because the questions always come in late, I want to ask, are we aware of anyone who's going over and doing fellowships in hospitalist training in the US? Has anyone on the panel had a trainee who's gone that route? No, I don't know of anybody. Mary, yeah.
Yeah, I mean, as Laura and yourself have trained in the States, they tend to be that three-year residency program in internal medicine, and the structure is quite different over there. While they've expanded the training you can do in hospitalists, they still essentially tend to be very good general physicians who've done 3-year residency program. And I think one of the challenges within the country is that different geographical areas and hospital levels have different needs. I'm an infectious disease doctor, so I would consider myself as one of the generalist type doctors that, like Laura, gets great satisfaction from curing people and diagnosing people who have fevers but never have infectious disease. They all just have rheumatological conditions, and really get that satisfaction from getting that diverse, I suppose, exposure to patients. And I always tell students when they say, "Oh, I want to do neonatology," or "I want to do IBD," somebody does not come into hospital and say, "I have Crohn's disease," or "I have mixed connective tissue disease." They come in with a story, and you'll hear Fergus Shannon talking about the story and listening to the patient. And that's what a good doctor is, whether you're a specialist or a generalist, is hearing the story and then diverting to the appropriate expert in the area.
Great, thanks very much. I want to just move on. I just like to ask just Hassan, and there's a few questions that have come. We want to acknowledge the talk and how the breadth of it. But one of the questions that comes in is Frank had touched on this, the expectations of doctors who come to work on non-training schemes in Ireland. There's different career trajectories. What's your view on that? What sort of career trajectories do you think exist? Is everyone looking to be a consultant? Some people career aims. What do you think about that?
I think it's a very good question. I think from my experience, I've seen people who are coming in from Pakistan and Sudan. They all actually want to get to a training scheme, or else they wanted to get recognized what they have done. There are people who have worked for registrar for like 15, 12, 15 years, and they're just stuck at the same level. And it's very unfortunate because we have a long waiting list of people to be seen by specialists, and these doctors are often very good, and they're very hardworking people. So I think everybody is to get down the specialist registrar and becoming a consultant. I don't think in medicine there are people who want to be in the same level. Maybe in surgery people refer to be registrars for life, but in medicine we all want to progress. And
so
that's
what would be, one of the questions is, what would be the most important change you would suggest for doctors not on training schemes at this point? What would be the most important thing?
I think to facilitate a pathway to get them onto the training scheme, or if they cannot get into the training scheme, then maybe to recognize what they have done so far. I think there should be the way progress, or to find an alternative pathway on merit basis to make the progress. I think the progression is the key here, not to be stuck in the same level. I think a lot of people are motivated because of this, and there's not a good way of human resources to use doctors who are demotivated. A lot of them are very hardworking people. I think we need to find a way to help them progress.
So just Frank, can I just bring you in there just to ask you a few questions? I mean, obviously you covered an awful lot in the talk. I think one of the I suppose one of the questions that we often have to think about is when we're putting the changes in place. Obviously, you mentioned increasing training numbers. One of the questions came in, the amendment to the restriction on internship passed the door this week and will probably be in law by the end of the year. How do you see workforce and training matching? How do you feel? Is that an absolute requirement? Do we train enough doctors to fill our posts?
Thanks very much indeed. I think we do train enough doctors to fill our posts. We have issues with retention, which, as you know, the college has been very interested in for many years. I think that if we have a training program that trains twice or three times as many people as there are opportunities, it would be very unattractive. So I fundamentally think having a system with two different, a track A of training and a track B of training, probably isn't a sustainable long-term solution. The background to this, I would say, is that I think Hassan's point is correct, that most doctors coming to Ireland want to undertake training. It's very few that don't want to undertake training. But we, I think, nationally just don't have that capacity to train. For instance, twice, there are about almost 3,000 non-training scheme doctors in Ireland. We simply don't have that capacity. And other jurisdictions are similar. They tend to be quite limited. They tend to take in people into training to match their workforce planning. We went to Holland last year and they have an annual, highly regulated intake of training based on a very precise workforce planning model. And many other jurisdictions are like that. So I think we do have to, in some way, track training into opportunities to make the training schemes attractive. And I think we have to be much more fair and honest to people who are coming from abroad to say that in the current situation, coming into non-training scheme posts, there isn't a likelihood that they're going to get into a training scheme post. And I think on the other hand, we should expand initiatives such as the IMGTI, bringing people into formal training programs for a limited number of time, rather like going to the US on a J1 visa. I think that's quite a good way of doing it, as well as expanding general practice training, increasing consultant numbers and increasing training numbers.
Thanks, Frank, for that. And I mean, I think it's always an inexact science, but I mean, we have a commitment and we have increased the number of training posts, and I think that's work in progress. But as you rightly say, it's a finite number, so other solutions are important. Can I just ask, because Conor is with us, the IMGTI scheme, one of the questions came in, what's your experience of docs training that program and not wanting to go back to Pakistan and Sudan? Have you seen that as a problem? One of the listeners had asked that question.
No, well, I think there are people who come and feel they do want to stay, but there isn't an option to stay. You know, I mean, it's pretty black and white, and so far it hasn't proven to be a major issue at all. And to be honest with you, the sustainability of the program depends on people going back, because these are people who are trainees in their own country. The whole idea behind the Global Code of Practice is that there oughtn't to be a brain drain from low and middle income countries to countries such as ours. So there are ethical issues around our taking trainees in from countries where they're badly needed and where they've already had a substantial state investment in their education and training.
So thanks, Frank. And the clock is here, so I wanted to ask Kathy. Kathy, you did a great surfing in Sligo is definitely the way to go. So one of the questions which is interesting before your talk was, should level 3 hospitals work to make them more attractive to NCHDs and consultants, maybe focusing on aspects to make themselves? What would your response to that be?
I would say we try very hard. And in terms of publicising ourselves, it's extremely difficult. A lot of how we would get our trainees is by word of mouth. If we make training experience nice and good for the trainees that we have, exam pass rates are high, which is always a difficult one. And I think if you work locally and a good environment locally, the word will get out. It's a small country and word gets out. In terms of us actually advertising ourselves, I've been looking at this for a while. The actual HSE, if you're looking from Pakistan to see, will you come to Sligo? Sligo is a black hole. There's nothing about the hospital. There's nothing about the training. I think that's something we need to work on. I think we need to publicise ourselves from that perspective better. But from an Irish trainee point of view, it's very much about word of mouth. If you treat them well, they will come. It's that simple.
Yeah, and I think the experience is quite unique. And again, I don't, but I mean, you know, the experience in general medicine would be different in level 3 hospital, level 4 hospital. Just have 2 other questions just came in. One is a comment that we need to ensure that all clinical leads always do time on the front line. You know, so the grant funding. So someone is basically saying this is about championing medicine. It's all part of what we do, and that we don't remove that from our remit. Maintaining CPD and GIM and specialty, I think. It is challenging, but we must try and do that, and that's the challenge of general medicine. So I don't know if there's any other comments. Mary, have you any comments or anything before we finish up?
No, I'm happy to wrap up with some of the points that I think are important here. Firstly, just to thank all the speakers. It's important for the college to debate and progress things that are actually relevant to quality provision of healthcare. We are the largest postgraduate training body in the country, and there are challenges, and we've heard them outlined here today. As you know, we've been advocating for training expansion of our training numbers, and we're successful in getting 80 new positions, the majority of which were in BST, but with some in HST. And we will continue to work closely with the HSE and NDTP to increase those numbers. While Frank does point out that we're training enough people, as Laura and Anthony frequently point out, there are a huge number of vacant posts within Ireland. So something that we aren't doing quite right. And it's not just about pay equity, it's many other issues that we will continue to drive for. No matter where you live in the country, whether it's in Tralee, where I'm from, West Kerry, the middle of the country, or one of the big cities, we should all have access to the best possible care. And our job as a training body and as a professional body is to advocate for that on a continuous basis. The other issue, and I think it's really important, and I think our college has been to the forefront of trying to push this, is the element of support that we have for our doctors that are not in training schemes. Life should be based on meritocracy. If you're good, you should get the job. There are areas that we are continue to work on within the college, like access to courses, our educational material, and Frank outlined that we're working closely with the NDTP to ensure that we can provide courses and educational material on a sustainable basis that gets acknowledged through with of course what the NDTP are doing with e-portfolios, and also continued access to examinations for everybody, which has been we are the first college to roll out remote invigilation within Ireland and the UK, and we are trying to get our clinical exams up and running to ensure that every doctor that wants to do an exam can do it, to ensure that they continue to get the training and education that they require. And really to continue advising on entry into the specialty division of the register. That's our job. Our job is to provide the best quality care for the population, not only in Ireland, but for all of those members that either train here or practice abroad. And in the next 3 years, I will continue to advocate and for the needs as I outlined, and will continue to work on your part. So again, thanks to all of our speakers, and particularly to Anto O'Regan, who's done a huge amount in working to strengthen the Institute of Medicine and work closely with our specialty societies to make Ireland, to have Ireland as the place to go for medical education. I think it is, and it should be recognised as such, thanks to the work of our trainers. So I'm hoping everyone stays on for the next session that starts in about 15 minutes. That allows everyone a cup of coffee, but it promises to be a good session on medical leadership and the experience of three very esteemed colleagues who will be talking on different aspects, and that starts at 4 o'clock. So thanks to everybody.